This is more of like an FYI. This is more, I think you guys need to know this for didactic. The sideline test tests the same thing as the Dix Hall pipe test. It's just another option if the patient can't do the Dix Hall pipe test. Usually they have like a lot of kyphosis or like postural issues that you can use a sideline test. The sideline test, you'll see with the Epley maneuver, like they still have to get into that other position if it's possible. So this is just to, I guess, to check it if you're not sure if they have it or not, but it's basically, you turn the patient's head and they lay down this way, and if you chop my head off my body, I'm basically in what Dix Hall pike?
Right.
The right Dix Hall pike. Yeah.
Oh, I see.
So that would just be an alternative to the right Dix Hall pike, and then same thing for the left. So just know that. You're not going to have to do this. You could do it, I guess, on the practical if you wanted to be different. But I think it's more for didactic that you guys are responsible for knowing that.
You said if they have kyphosis or that.
Yeah, if they're like, those like, with Parkinson's, people with, they walk in like this, like you're not gonna get them. It's not gonna be like me teaching with one of you guys, like doing it with perfect neck extension, everything, like it's. So then I'm like, and they're like, yeah, when I get out of bed, I get the spins, like you could just say like, I don't know, the blood pressure stuff for you, or like, let me just check the sideline test real quick, and then if it's positive for BPPV, then you figure it out later how you're going to do the maneuver. We angle tables. I put those big wooden boxes under the. It's sketchy, and you're not supposed to do this, but I do that anyways to change the angle of the table so that their head is still down even without getting extension. But I try to get creative, and then they're also. This is more in like ENT doctors' clinics. There's something called an Epley chair or a TRV chair, where they basically sit in, think like astronaut trainer thing, and it just moves their whole body. There's no neck movement at all. It just moves their whole chair body in through the full maneuver. So that's like if somebody has like a crazy cervical fusion surgery, like that would be like an option for them. Okay, so we checked out anterior and posterior on both sides with our awesome Dix Hall pike test. What are the two canals that are left? Horizontal canals, which we're going to test with our roll test. So I have Yano here, who is going to, if you put your legs up, maybe scoop away a little bit. Right there is perfect. So this one, because of, again, the angle of those horizontal canals, we have to have her head in flexion, her neck in flexion, because they're up like this. So we need them to be perpendicular to the ground for this test. So I'll have you go ahead and look straight ahead, lie straight back, just like this. So she's in that neck flexion there. That's even a little extreme. Right there's good. And then this one you would be standing as the examiner, because if I'm sitting and she's in neck flexion, how can I see her eyes unless I'm peering over and just being in their face? So I stand for this one, and the test still hasn't started yet. So we're just setting up, which is different than the Dix Hall pike where you got it all down at once. So we're just in midline. And so to test on the left Dix Hall pike, I'm just gonna have you turn your head to the left. Please keep your eyes open. 1, 2, 3. And I'm looking at her eyes. And here, I would expect to see one of two types of nystagmus if it's a positive test. That would be geotropic or agiotropic. So geotropic is geo, like the ground, like earth. So it's beating fast down towards the ground that way. Agiotropic would be beating fast up away from the ground this way. So then I would go back to the center, and then I would do the same thing on the opposite side. And the weird thing about horizontal canal BPPV is you're probably gonna see, there's several weird things, but you're probably gonna see it on both sides, even though only one ear is involved. So, how do you find out which ear is the problem? Where the problem is located? So for geotropic nystagmus, this can be confusing for some people. And you can go back to the middle. For geotropic nystagmus, you see it on both sides. For any type of nystagmus, for the roll test, you're asking the patient to rate their symptoms. So say on the left, she is that's like barely anything. That's like a 2 out of 10 vertigo. And then she goes to the right and she's like, man, that's crazy. That's like 10 out of 10 vertigo. So I know that the right side is involved. So my diagnosis would be right horizontal canalithiasis. Right horizontal canalithiasis.
Down, right, G up.
Yep. And so there's no twisting, there's no torsion. It's just like this way. So if it's agiotropic nystagmus, beating away from the ground, also called apogeotropic, whichever people want to call it, then it's the side that is less symptomatic. So if I go over here and she says 2, if I go over here and she says 10, that's a left horizontal cupulolithiasis. Yeah. Oh yeah, and I didn't mention geotropic means canalithiasis and agiotropic means cupulolithiasis. So you'll notice that time frame doesn't matter on this test. It really does on the Dix-Hallpike test, not this one. We're just looking at direction of nystagmus and intensity. Those are all we need. So yes.
Have you ever seen horizontal?
Cupulolithiasis?
Or cupula or canalithiasis?
Oh, yeah.
You've seen it? Oh,
Yeah,
they say
yeah.
it's very rare in
Yeah,
videos.
that was rare, not ever.
It's not.
Oh, really?
So it's like 10 or 15% of cases in outpatient, but what they found out in the last year is that it's like 50% in the emergency department. So why the difference? So they say that for horizontal canal BPPV, the symptoms are more severe. So it's like more alarming to the person and more severe, which would cause them more to go to the emergency room. And they're also so one thing, 80% of BPPV gets resolved with no treatment. It just goes away over time. The people you meet is the ones that it didn't. So horizontal canal, even though it's more severe, it's actually more easily converted back to normal just with rolling around in bed. Because you just got these horizontal canals, they're just big simple hula hoops. And so if you turn one way or another, like the treatment, the barbecue roll that we'll teach you guys, it's just rolling around in a circle and holding your head a certain way. So it's not that special. So people could do it, fix it on accident, basically. So between it being more severe, sending people to the ED, and it being fixed on its own, not even making it to outpatient because it got fixed already, that's why it's more common in emergency.
From the visual presentations, that basically telling us that anterior and posterior are common, and horizontal you'll never see.
I swear on my life that is not true. Anterior.
That's why I was thinking when you were saying how anterior is super rare. I was
So
is
rare.
it talking about horizontal?
No, 100%. Anterior, usually, there's a lot of weird theories about anterior. Some people don't even believe it exists. That's not true, I don't think either, but most of the time for anterior, there's some weirdo story, like they were doing inversions in yoga class or something like that, or I had a lady fall, almost what's the wrestling move where you drop their head down on Yeah, where she basically tripped over something and landed like that. Top of her head on the ground. And that's how she got anterior canal. Pile drive, whatever. But so it's because that superior canal, that anterior canal is up like this. How'd you shoot something up into that canal? So something weird's probably happening, or they have weird anatomy where there's sags, whatever. But it's very rare. This is kind of rare, but I see it all the time. If I'm seeing a couple people that have this every day, like, and it's 10% of cases, like, I'm gonna see it kind of frequently. So yeah, so you take the patient back, test hasn't started yet, you go to the left, you ask them their symptoms and monitor what type of nystagmus it is. You go to the right, you ask them their symptoms. So we'll do a pseudo case for you, or like a mock case for you guys. So I'm gonna have her turn to the left, and I see fast beating nystagmus that is beating away from the ground, and I say, Yanua, what level would you rate your symptoms here?
2.
2. I'll pick a different number.
Okay.
10, okay. And then we'll go on this side. What about over here?
2.
2, very good. And again, it's not gonna be close. It's not gonna be like 5 and 6, you know, it's gonna be like 1 in 10 or 2 in 10 or something like that. So we have a 10 over here and a 2 over here and agiotropic on both sides. So
Right side and horizontal.
Left side.
right side. This is our 2 over here. So because it's a less symptomatic side, and for agiotropic, we're looking for the less symptomatic side. For geotropic, it's the more symptomatic side.
Good meat stand out.
Yeah. Does that make sense to people?
One more time.
Yeah. So you're probably going to get a positive test on both sides, whether it's no matter what type of nystagmus it is. So you're then seeing is it agiotropic or geotropic, and just logging that in your head. If it's agiotropic, it's cupulolithiasis. If it's geotropic, it's canalophthiasis. And then you're asking the patient to rate their symptoms on both sides. So for the normal one, the regular one, it's the most common geotropic canalophthiasis, then it's the higher one. That makes sense, right? That the higher one is more involved. For the weird one, the cupulolithiasis, the agiotropic one, that one, the less symptomatic ear is the involved side. So one more case study here. So I turn the patient's head to the left, and I see geotropic nystagmus that's fast beating down towards the ground. And what do you rate your symptoms at?
10.
10, okay. And then over here,
2.
2, okay. Big 210 person over here. But so we have a 10 and a 2 with geotropic on both sides. So what's my diagnosis? Left horizontal canalophthiasis. Good. And the reason all that matters is because how you fix it is just a straight up a different maneuver. And then in terms of right and left, the reason that matters is because which side are you treating? This will be the last thing we practice and do today. So we'll go into treatment at our next lab. We'll cover treatment at our next lab. Because you guys were running early. I want you guys to be able to get out early today. So we'll break out, practice the roll test. I'll pick some people to demonstrate, and then we'll call it a day. All right. 1, 2, 3.